Welcome back to a Pediatric Dentist channel Tiny Tip Talks. If you are new to this channel, subscribe the channel, and for details of this channel, visit the bio section, or you can also check out my previous videos. There are behavior modification techniques to reduce dental fear, anxiety and phobia in child, but to apply such techniques, we need to assess the level of dental fear, anxiety and phobia in child. And for that, there are many psychometric assessment scales available. So today we are going to cover fear and anxiety scales used in dental operatory, which is an important topic for both theory and your daily dental practice. There are many tests for anxiety and fear evaluation. About they are primarily divided into two types. First is observation of child's reaction or behavior by dentist or other person during dental treatment, and second is reports of anxiety made by child himself or herself or by the accompanying parent, most often the mother, using psychometric scales. So these are the commonly used fear and anxiety scales, and this is an image given in your textbook by dividing it in three categories, but they didn't explain all the scales written in this table. In my videos, I will cover all these scales, plus I will also discuss recent advances. So let's start with the scales used in adults and children. First is Cora's dental anxiety scale. So the most widely used measure of dental anxiety, the dental anxiety scale DAS, was originally based on a single item question that was developed to measure psychological stress, and this scale is given by Cora and Pantera in 1969. So these are the Norman Cora's dental questionnaire. All come with the five option: relaxed, a little uneasy, tense, anxious and so anxious. So the four question in the dental anxiety scale relate to scenarios varying in temporal and distal proximity from the dental experience. Presumably, increased physical and temporal proximity to dental encounter was believed to be related to increase in anxiety, and this has formed the basis of other scales. This scoring is for us, not for the patients. A is equal to 1, B is equal to 2, C is equal to 3, D is equal to 4, and E is equal to 5. So 5 option and 4 questions, so total is 20. If score is in between 9 to 12, then moderate anxiety but have a specific stressors that should be discussed and managed. If it is 13 to 14, then high anxiety. If it is in between 15 to 20, then severe anxiety or phobia may be manageable with the dental concerns assessment, but might require the help of a mental health therapist. So the advantages of this scale is it can aid the dentist to be aware of what to expect from patients and take measures to help alleviate the anxiety of the patient. It can be self-administered in the waiting room in 2 minutes. Disadvantage is the dental anxiety scale is widely used but has a criticized for exhibiting a range of scores too narrow to be used effectively in clinical studies. Then the second is modified dental anxiety scale. In 1995, Cora's dental anxiety scale was modified by Humphreys et al. To overcome its shortcomings. Humphreys et al. Added a fifth question relating to local anesthetics, as it is a major cause of anxiety for many individuals. So these are the five questions. Each item scored as a non-anxious, slightly anxious, fairly anxious, very anxious and extremely anxious. So the score is the sum of 5 items, so range between 5 to 25, and cutoff is 90 or above, which increase highly dental anxious patients, possibly dental phobic. The answer options were also modified to non-anxious, slightly anxious, fairly anxious, very anxious and extremely anxious, so that the same options were available for all five questions, and they were rephrased to be in a clearer order of anxiety. The third is Kleenex Dental Fear Survey. So the second most commonly used measure of dental anxiety and fear is a dental fear scale, originally developed as a 27 item scale by Kleenex et al. In 1973 and subsequently reduced to a 20 items as a result of a later factor analytic study. So these are the first seven, And then these are the 8 to 20 question. So scoring and interpretation is ranging from 20 to 100. So 20 to 40 low dental fear, 41 to 70 moderate dental fear, 71 to 100 high dental fear. High scores suggest the need for behavior guidance techniques such as the tell, show, do, distraction or sedation. But the disadvantage is, despite the dental fear survey being widely used as a measure of dental fear, the scale was not developed to produce a single fear score, but rather to provide information on a variety of specific stimuli that might elicit fear or avoidance responses, as well as the patient's specific and unique responses to those stimuli. The fourth one is dental fear anxiety scale. The dental fear anxiety scale DFA is less standardized than tools like modified dental anxiety or dental anxiety scale, and multiple versions exist under similar name. However, based on the literature, dental fear anxiety scale typically refers to a multi-item Likert types questionnaire assessing emotional, cognitive, and behavioral aspects of the dental fear. So these are the questions they generally ask, with the response strongly disagree to strongly agree. So scoring is total scoring is a sum of all item, which is 7 to 35 for 7 items, and higher scores indicate greater dental fear and anxiety. You have to take a notes that first, the dental fear anxiety scale is sometimes used interchangeably with or adapt from the other scales like dental anxiety questionnaire or dental fear survey. It is not a universally standardized tool, so item wording and number may vary across studies. If you are using that in a research or clinical work, it is best to cite the specific version or adaptation used. Then the fifth is Gesell's 10-point fear scale, which is developed by Robert J. Gesell in the 1970s as a part of broader research on dental fear and pain. It consists of one question asking the patient to rate their fear of dental treatment on a scale from 1 to 10. It's often used in a combination with the other scales like dental anxiety scale or dental fear survey to provide a quick snapshot of the patient anxiety. So the question is, on a scale from 1 to 10, how fearful are you of dental treatment? And response is option is 1 to 10. These are the interpretation of the options. If it is 1, then no fear at all, 2 very mild fear, 3 mild fear, 4 slightly discomfort, 5 moderate fear, 6 noticeably anxiety, 7 higher anxiety, 8 strong fear, 9 very strong fear, and 10 is extremely fear or panic. So if the scoring is between 1 to 3 low fear, 4 to 6 moderate fear, 7 to 10 high to extreme fear. The advantages include quick and easy, take less than 30 seconds to administer, intuitive, patients easily understand the numeric rating skills, useful for triage, helps identify patients who may need further anxiety management or sedation. Limitations: lacks dimensionality, doesn't explore specific triggers, for example, fear of needle drilling, no psychometric depth, not validated for reliability or construct validity like modified dental anxiety scale or the dental fear survey. Subjective interpretation: patients may rate based on mood or recent experiences. Clinical use: often used as a pre-screening tool in dental clinics, can be followed by more detailed scales like modified dental anxiety scale if the score is high. Useful in pediatric settings where longer questionnaire may be impractical. Sixth one is the Stouthead's dental anxiety inventory, developed by the Stouthead, Mellenberg, and Hoogstraten. In 1993, the dental anxiety inventory was created using a facet design approach to capture the complexity of dental anxiety. It aims to assess not just the presence of anxiety but its contextual triggers and manifestation. So the facet structures include three core facets. First is time, second is situation, and third is reaction. For time, elements are at home, on the way, in the waiting room, in the chair. Example: I feel anxious while traveling to dentist. So they have to agree or disagree between 1 to 5. Situation is introductory phase, dentist patient interaction, actual treatment. I feel nervous when the dentist explain the procedure. Then reaction: subjective feelings, physical symptoms, cognitive thoughts, that my heart raced during the dental treatment. They have a short version which include 9 to 12 items selected for brevity and clinical feasibility. And these are the response format, and the interpretation is higher score and indicate greater anxiety. Subskill scores help identify specific triggers. Advantages are validated in multiple populations, strong correlation with other popular dental anxiety scale, differentiated between the general anxiety and dental specific anxiety. The 7 is Gale's IQ scale. Gale's IQ scale referred to the Stanford Binet Intelligence Scales 5th edition SB5 developed by Gale H. Royd. It assesses cognitive abilities across 5 key domains using both verbal and non-verbal subtests. 5 cognitive domains are fluid reasoning. They predict ability to understand new procedure or adapt to unfamiliar environment. The knowledge indicates general understanding, help tailor explanation. Quantitative reasoning less relevant directly but may reflect broader cognitive maturity. Visual spatial processing useful for understanding diagram, positioning, modeling, oral hygiene, and working memory, critical for following multi-step instructions and coping with anxiety. So these are the domain, these are the subtests in the domain, and these are the sample question responses and dental relevance, and these are the interpretation. The scale should be interpreted in the IQ range. So IQ range is above 130, then gifted, use advanced explanation, involve child in decision making. If IQ range is between 110 to 129, then high average, standard communication behavior techniques effective. 90 to 109 average, age appropriate instruction and modeling. 80 to 89 low average, dental strategies should be use visual aids and repetition. 70 to 79 borderline, short appointments, simplified language, caregiver involvement. And less than 69 intellectual disability, tell show do, desensitization, visual schedules, caregiver supports. How to use these in a practice? So before visit, use brief IQ screener, which is a object series plus vocabulary. So these are the object series plus vocabulary. Then during treatment planning, match communication style to verbal IQ and non-verbal IQ. Adjust appointment length based on the working memory. Use visual aids for low verbal or fluid reasoning scores. For anxious or special needs children, refer to full SB5 if needed. Collaborate with the psychologist or special educators. Pediatric dental relevance: if the patient has a low working memory, may struggle with the multi-step instruction, use visual aids and repetitions. Weak fluid reasoning, may not adapt well to new procedures, use tell show do and desensitization. Strong visual spatial skill, can follow brushing diagrams or model placement easily. Limited vocabulary, use simplified language and visual cues. We will discuss the other skill in the next part. I will give you all the references together after the end of all parts. Mostly we discuss 3 parts. If you want these as a PDF or any other PDF, just like, subscribe and comment or mail ID with the topic and I'll share you the PDF. New videos on Sunday. We also put image based MCQ in pediatric dentistry in our shorts, and we'll put lots of other type of MCQs. We already started topic of the week series related to pediatric dentistry. So press the bell icon for every update. Like, share and subscribe. Thank you.